Good afternoon, ladies and gentlemen. We welcome you once again to one of our sessions this afternoon, and thank you for joining us. So today we are going to be discussing about HIV and the PrEP services, as you can see on the poster, whereby we are having a very interesting topic, integrating PrEP and sexual reproductive health services. Whereby we are going to be discussing all these things: what is PrEP, the overview of PrEP services in Kenya, delivery of integrated services. We'll have a talk by LVCT and the plenary session, and have a plenary session in the end. I'd like to welcome our hosts, our speakers who are with us, and from NASCOP team from LVCT Health. I'll welcome Mary. I'll welcome I welcome Ruth Kamau. Sorry for that. I welcome Ruth Kamau to take over the session and introduce herself, introduce the speakers with us, and take over the session. Karibuni sana. Feel free to put in your question and answers in the Q&A section, and we'll have a session in the end to just go through that and discuss all matters to do with PrEP services and reproductive health services and how we integrate them. Karibuni sana. I'm Dr. Karingo from Kenyatta National Hospital Medical Research. Over to you, Ruth.
Thank you, Dr. My name is Ruth Kamau. I work with NASCOP as a program officer coordinating PrEP activities in the country. So this afternoon, our manager, Mary Mugambi, is not able to join us. So I'll be taking over the session and the presentation that she was to make this afternoon. So I'll take the first presentation. Allow me a minute to share. And the focus of our presentation this afternoon was just to look at pre-exposure prophylaxis, which is one of the youngest HIV prevention program in the country that we are implementing, to see the achievement that we have been able to make in the last 4 to 5 years the program has been in existence. Thank you. So the outline of the presentation is that we have a brief introduction. We look at the data, what we've been able to achieve, and maybe just focus why integrate PrEP and SRH. And we begin with the background of understanding what is PrEP. PrEP means pre-exposure prophylaxis. This is a HIV prevention strategy in which a HIV negative person at a substantial and ongoing risk of HIV infection takes daily antiretroviral drug to prevent HIV. I know here we have talked of antiretroviral, but the landscape is changing, and new products are coming. Upon their approval and licensing, they will be made available. So as a country, we are implementing what we call combination prevention approach in HIV prevention. And this is providing a package of services. So the providers, healthcare workers, as they offer services, should be able to counsel clients on all the available options and allow them to make an informed choice of the HIV prevention intervention to make. We have behavioral intervention, which focuses on addressing behavior like risk reduction counseling, correct and consistent use of male and female condoms, and we have evidence-based behavioral interventions. Then we have the biomedical interventions. We have PrEP there, voluntary medical male circumcision, post-exposure prophylaxis, prevention and treatment of STIs, effective ART use for the HIV positive persons, PMTCT and HIV testing services. Then we have structural interventions like enrolling, ensuring that our girls and boys remain in schools, economic empowerment so that they are not vulnerable, and then addressing societal norms that perpetuate GBV and other forms of violence. As we implement this combination prevention, PrEP's follow-up for PrEP provide us with a good opportunity to be able to implement these other interventions. Like for example, when a client is coming for the follow-up on PrEP, it gives the provider an opportunity to institute risk reduction counseling, another and so that the client is able to appreciate their risk and minimize them. So for you to offer PrEP, there must be a risk. And we identify this risk through a process we call risk assessment. And we do this by asking a series of questions. And if the person answers yes to any of the questions, then they are at a substantial ongoing risk, and they should be evaluated further for PrEP services. And examples of those situations that put people at risk are a person whose sexual partner or partners is of a known HIV status, or the person is at a high HIV risk. If you do not know your sex partner HIV status, then that puts you at risk. A person with history of sex while under the influence of alcohol or other recreational drugs, a person who uses condom inconsistently, or a person who is not able to negotiate for condom use during intercourse with person of a known HIV status, a person with history of recent or current sexually transmitted infection, a person who is a user of post-exposure prophylaxis recurrently, they keep coming back that they had a needle stick, they had a burst condom, that a person who should be on PrEP instead of them coming for PrEP frequently. A person whose sexual partner is HIV positive and they are not on ART, or they are on ART for less than 6 months, or they are suspected poor adherence, or a person in a serodiscordant relationship when they are trying to conceive. And we also have people who are engaging in transactional sex or sex work, or a person who using injection drug use where syringes and needles are shared. These are some of the situations that put people at risk. And as I said earlier, if a person answers yes to this question, they should be evaluated further for eligibility for PrEP. And so what are some of the eligibility parameters? We said PrEP is for HIV negative. So a HIV test must be done before initiation of PrEP. Then upon further evaluation, there should be no contraindication to tenofovir. Then evaluated and found to have no severe renal disease, and they should be weighing over 35 kgs. Then after they have achieved all these, they should be willing to take a PrEP and also the associated follow-up. So we have some, currently, we have some products that we are currently using for PrEP. We have daily oral PrEP, which we can use either tenofovir and amitriptyline, or tenofovir and lamivudine, or tenofovir only. We have a new dosing regimen for PrEP, that is the event-driven PrEP. These are 2 doses taken 2 to 24 hours before sexual exposure, 1 dose after 24 hours, and another dose after 48 hours. We also call it 2+1+1. This is only for men, people who are born biologically male. Then we also have a new product that is coming on board, that is the dapivirine vaginal ring. This is only for females. It is a ring that is inserted and it says in situ for 28 days. We also have other products that are in the pipeline. Long-acting cabotegravir injection, which is given every 8 weeks. It has passed, it's been approved by FDA, and we are waiting for it to be reviewed and approved by WHO. Once approved, it will be available for use in the country. The other products that are still undergoing trials is that we have islatravir monthly tablets. We have multipurpose technologies that are being developed, which combine HIV prevention and contraception. With this could be rings and implants. So how have we done in the last 4 to 5 years that PrEP has been implemented in the country? We have around 2,087 facilities that are offering PrEP countrywide. This has been a slow but gradual increase, but now we have PrEP in all the 47 counties. We have a total of about 180,000 people who have ever initiated on PrEP since it was included in our guidelines in 2016. And we can see when we look at that breakdown per population, we have more people who ascribe themselves as general population taking up PrEP, followed by discordant couples. And then we have female sex workers, and a small proportion goes to MSM and person who inject drugs. Comparing the number ever started and number currently on PrEP, we have about 939 who have ever started. However, our continuation on PrEP remains low. Like in December, you can see we had only 56,000 who were on PrEP. However, PrEP is not meant to be a lifelong intervention, and it is only indicated during seasons of risk. So it is okay for our clients to start PrEP, and maybe 2-3 months down the line, when their risk profile has changed, they can discontinue and restart later when they are at risk again. These are just a snapshot of how we have done with our initiation in 2021. So we have significant numbers who are initiating PrEP every month. However, we can do much more and much better than this. Looking at the numbers that are currently on PrEP, half of the year 2021, you can see our continuation rates remain almost the same. They are always less than 50%. But as I've mentioned earlier, PrEP is not meant to be a lifelong intervention. So when we look at those people who remain on PrEP by their population, we see despite the fact that we have more general persons who are from the general population taking up PrEP, we have more discordant couple remaining on PrEP for longer. This can maybe be attributed because this is a population we are following up in our HIV care clinics. We have more access to them. We have put adherence strengthening mechanism towards this population, and this could be the reason that maybe makes them stay on PrEP for a bit longer. However, we have a significant proportion from the general population who also remain on PrEP, followed by FSW and then MSM, and a small number of persons who inject drugs. And so as I finish, it's important for us to ask ourselves, why should we integrate services? I take you back to data from our 2020 estimate. We can see that 42% of all adult infections occur among the youth. And when we look at our HIV prevalence, female experience more HIV prevalence. And these are the same women we are seeing in our MCH, FP clinics on a daily basis. And it's important to note the same sexual acts that are transmitting HIV as the same sexual act that are giving them pregnancy. So it is important to focus on them. A little more on the data. So women of reproductive age in Kenya have high rates of both HIV infection and unintended pregnancy. So women have a higher prevalence rate as compared to men. And when we look at the KNH-UoN report 2018, 23.6% of all these new infection occurred among women, adolescent girls and young women, that is between maybe 15 to 24 years. A programmatic report showed only a 22% uptake of PrEP among HIV negative women accessing routine EP services. And then we still have high unmet need for contraception among HYW who do not want to get pregnant. So if we really combine these services, we are able to address two problems at the same time. And some of maybe benefits that we have. Kenya has a rich policy environment that supports integration. So we can ride on these existing policies so that we integrate our services. And some of the benefits to the clients could improve access to services. We have client satisfaction, and then we also are able to avoid missed opportunities. And when we look at the health system, there is good utilization of human resource and in the infrastructure, because the same room where you're offering your contraception is the same room and the same provider who will offer the same PrEP services to this client. Then there is also improved cost efficiencies. They reduce the burden of caring of HIV infected person. If this woman comes for contraception and you fail to screen them for HIV risk and she ends up contracting HIV, she will still come back to the health system, maybe with a HIV, with a pregnancy and a HIV exposed infant, and you need to care for them. And HIV care, we know, is a long-term care. So when we protect them during antenatal, when they are coming for contraceptive, we are saving on costs that we could have actually spent on caring for them when they test HIV positive. So it is important to remind us that majority of adolescent girls and young women have low perception of their HIV risk, and they tend to fear getting pregnant more than they fear HIV. So when they come to us for other services, we should also endeavor to screen them for HIV risk and offer them appropriate services. The same sexual activities that will make the woman pregnant is the same sexual activity that will end up giving them HIV. So when they come to us, they are asking for contraception. It is a communication. They are telling us that I am having unprotected sex, and we should take this as an opportunity to make sure they are protected in every aspect. So thank you. We can type our questions on the chat, and we'll have a Q&A session and we'll respond to them. But we'd like to move on to the next presentation. I will introduce Patricia Jekonaya. Patricia works with LVCT as a policy advisor and health system strengthening officer. She will give us more details about herself as she makes a presentation on LVCT experience of implementing integrated services within Nairobi County. Patricia, over to you and welcome. You can share your screen and proceed.
All right, thank you very much. So kindly just give me a minute. I put up my screen using my laptop. I would like to just change the gadget I'm using. All right, thank you for putting it up. So I will just proceed. So as Ruth has said, my name is Patricia Jekonaya. I work with LVCT Health as a senior technical advisor for policy and partnerships, and also a program manager on introduction of new HIV prevention methods. So, and I would like to share with us today results and lessons that we learned from a quality improvement initiative that aimed to integrate oral PrEP into family planning services in Nairobi to increase uptake of oral PrEP amongst the adolescent girls and young women. Just go to the next slide. That is the outline. So the goal of this project was to increase access to and uptake of oral PrEP amongst adolescent girls and young women by integrating oral PrEP into FP services. And as we have already seen in the data that has been presented by Ruth, breaking down that data into adolescent girls and young women has been a major challenge. But of course, also as we see the disaggregation by population, we realize that not so many adolescent girls and young women are on oral PrEP. However, we are seeing new HIV infections coming from the same population. Next. So the project set out to achieve three main objectives. One was to engage with the county, the sub-county stakeholders and staff to select facilities and also agree to apply a quality improvement method and champion the integration of PrEP and FP services. The second was to identify the tools, the practices, and facility level changes that were required for effective integration. And lastly, to disseminate the results of a quality improvement collaborative to promote utilization of PrEP, FP integrated services. Next. So at the initial stages of the project, we agreed to apply the Plan, Do, Study, Act methodology of quality improvement. And so the facilities that were selected had to go through identifying what was the problem and where they were at the time when we started with them. And so in terms of integrating oral PrEP into FP services, all of them were starting at 0. And then analyzing what exactly was the root cause of the problem, then developing the plans, and they were able to implement, to study what was coming out of the initiatives they had put together and acting on it, and then constantly doing this cycle of evaluating, identifying additional bottlenecks and continuously addressing them. Next. So just to share with you a snapshot of the collaborative process that we went through. So we engaged with an NMS, the Nairobi Metropolitan Services Health Management teams, and that was done in February of 2020. Then we discussed and agreed on the facilities that were to participate in this, conducted the entry processes so that we get the buy-in and support, and then also gathered additional input from the FP providers and AGYW as clients in terms of what they would like to see in an integrated service. Then we conducted a quality improvement planning workshop, which was virtual. Remember, these were the days when COVID-19 had also hit the country really hard. So we did this first planning workshop, then went ahead to review the training approach, the methodology, and the tools that were utilized. Did this together with NASCOP and also involved the Department of Reproductive Health. And then once the tools were ready, we rolled out the training in December. However, we had to do this training in 2 parts because of inability to have physical meetings. So we did the first part and then did the second part in March, and then went ahead now to start offering services from April of 2021, and all this continued to October 2021. In between, there were joint supervisions, there were trainings for ambassadors to create demand for the services, and there were also learning forums that would bring these 3 facilities together to share their experiences. Next. So the facilities that participated in this were Mukuru Health Center in Embakasi East Sub-County. We had Kangemi Health Center in Westlands and Lunga Health Center in Makadara. And these 3 facilities were selected because of the number of clients that they had coming for their FP services, but then also based on the number of targets they have to enroll young women on oral PrEP. Next. So at the initial stages when we were interacting with the providers and agreeing on what the approach for integration would look like, there were 3 major approaches to this. The one that is currently also being piloted by NASCOP, which is known as the one-stop shop, where one provider offers all the services. Then there was the supermarket approach, where you have different service delivery points within a facility, but then it is facilitated referral. So you move, for example, from FP room, you're taken to the HTS provider, then taken to the CCC to pick your, to get further eligibility assessments and then be initiated on oral PrEP. And then there's also the mall model where you could actually move from different facilities. So the 3 facilities unanimously agreed on the supermarket approach, which is the facilitated referrals. Next. So we went through the national tools and strategies that were available that pointed to integration of HIV into sexual reproductive health services, and ended up coming up with the standard operating procedures that were very clear on how clients were to move from one room to the other. And also the training materials, we borrowed a lot of them from the FP training curriculum and also the oral PrEP curriculums, and also developed some job aids to support the providers. Screening tools were also adapted appropriately, and we developed additional M&E tools that would help us see the flow of integration, and also utilize already existing demand creation materials to train ambassadors, and also for the ambassadors to begin to do demand creation at community level, and also to support at facility level. So as we move on now to the next slides, we'll be sharing the data, the indicators that were measured, key lessons learned from this pilot. So we had 5 major indicators that were going to demonstrate the PrEP FP integration. Indicator number 1 was the percentage of FP clients who were screened using the risk assessment tool for indications for referral for further PrEP assessment at the health facility. Indicator number 2 is percentage of clients found to have indications for referral for further PrEP assessment to the facility upon completion of the RAST tool. Indicator number 3, percentage of FP clients found to have indications for referral for further PrEP assessment at the health facility upon completion of RAST referred for PrEP. Then the 4th indicator were of those referred for PrEP, how many were eligible for PrEP. And lastly, of those eligible, how many were initiated on PrEP. So it would track a client from the FP to the PrEP service delivery point until the client is initiated. And just to point out here that when we were doing the trainings, the FP providers also came out and asked if they are the ones who are going to support, PrEP meet their targets by referring clients, how are the PrEP service providers also helping FP meet their targets? So there was also the other way around of this tool, where if a client's entry point was at the PrEP service delivery point, then they would also be assessed for FP need and linked for FP services. Next. So in terms of the outcomes of this particular project, if you can take note that this data was collected from April of 2021 to October of 2020, and you probably have questions why there was a delay in starting the services immediately. So in between this particular project at the initial stages, there was a healthcare providers strike, and we experienced a number of shortages of commodities that really affected the uptake of these particular services. But from April to October, this is the cascade. And each of these facilities, Mukuru had 2,682. And as we went down the cascade following each of the indicators, the first thing you also realize is that the screening for PrEP needs was not done 100%, and it was a requirement within the project that screening be done 100% because this is using the RAST tool. So Mukuru, for example, did 86%, Lunga did 39%, and Kangemi did 43%. Now, on from the ones who were assessed, Mukuru was able to identify 5% of those assessed who had a need for to be referred for oral PrEP, and then ended up referring 95% of those. And of the 95% referred, they found 32% of them being eligible for oral PrEP. And finally, 71%, that is 29 people out of the 44, were initiated on PrEP. So the cascade moves the same for all the other 3 facilities. And just to highlight here that some of the missed opportunities are at the initial stage, the first contact with the first provider, to be able just to do RAST and see whether somebody is actually at risk and could benefit from HIV prevention services. Next. So the other way around, where we had the PrEP providers also screening for FP need, in Mukuru, interestingly enough, of all the 42 that were that entered through PrEP, 13 of them were screened, but none of them had a need. And in the other 2 facilities, we had Lunga Lunga with 16, ended up putting 8. And then of the 50 who entered through PrEP in Kangemi, 2 of them were found to need FP services and were also put on FP services. Next. So just to help us understand the results, the overall uptake, as we realized, was actually low. During that implementation period, we had 77 FP clients initiated on PrEP. But I think for us also, we said this is not loss. It actually opened our eyes to missed opportunities that we've had with FP clients, that we can actually screen and find people who are eligible and have them initiated on oral PrEP or on any other HIV prevention method of choice. We also observed a wide variation in performance on the key indicators across the 3 facilities, very high drop-offs, and our lessons learned will also help us understand why that happened. Also to point out that the project was not designed to assess PrEP continuation amongst those who were initiated, neither did it assess the satisfaction of those who received the integrated services. And lastly, that routine QI coaching, QI meetings, support supervisions that took place, and documentation of reasons for the decline of services also gave a lot of insight that there were clients who were found to be eligible, but they still declined to take up the service, and they gave reasons which we also documented. Next. So these are just some of the photos. We held 2 learning forums where people really shared, and if you can look at the one on the extreme right, at the corner there, we have presentations that were handmade by these facilities and were put up as part of just motivating them to continue doing their work. And it was also a challenging time because the facilities that did very well were able to share strategies that others could also learn from. Next. So a summary of the challenges in terms of the context related challenges, we had COVID-19 that really affected services. There were decreased uptake of the services. And also there was a healthcare workers strike that happened during the period of this project. And lastly, there was a huge shortage of the HIV test kits. And we know prevention begins from first the knowledge of status, then you can be able to make a decision to take up other services. So the facility and staff related challenges, one, we had reluctance by some of the providers to integrate services, and the main excuse was high workload. So as we move towards integration as a country, I think we need to unpack, this huge elephant in the room called workload, because the very first thing when we presented this idea of integration, number one was we have high workload already. So how are we supposed to do that? How am I supposed to hand over one client, to another provider? But also bringing in the idea of, can you offer all these services as one provider? There was equally a lot of resistance. And we had, for example, FP providers saying they've never been trained on delivery of oral PrEP, and they found it a major challenge. that equally showed us, the way we do orientation when we have new providers joining a facility really matters, because people tend to own their spaces, own the job that they were given, and they do not want to go out of their routine to try out something new. There was also negative attitude. Remember that this project looked out, to improve uptake amongst adolescent girls and young women. So the provider's attitude really played a major role here. There were providers who were reluctant to enroll a girl. One case in point is we had a high school girl, I think she was about 17 years, came for us for a service in the facility and said that she wanted oral PrEP because she had a boyfriend and they had closed school, and she really understood her risk. Then the provider asked this girl, when are you going back to school? And the girl said in 2 weeks' time. So the provider said, I cannot put you on oral PrEP. If you're going back in 2 weeks' time, you will not finish your dose. So right there was a missed opportunity and a misunderstanding of how oral PrEP operates and how providers, the main role is to be able to help this client make the right decision to avert a new infection. We had high rates of transfers and attrition amongst the trained providers being moved from one facility to another. There was a lack of cohesion between PrEP, FP, HTS. Each of these providers felt like they were doing the other provider a favor. So there was a greater need to help them work as a team. Inconsistency in documentation of the M&E tools. Again, here the providers voiced their concern of additional tools and requested whether the tools could actually be made as e-records to make it easy for them. There are inconsistencies in terms of administering RUST, and what we realized, the providers were actually uncomfortable with the questions, especially the FP providers, asking someone if they have multiple sexual partners, and they're like, how do you ask a woman that question? So there's need to help providers internalize this risk assessment tool. High expectations, and this one's always come up when there's a new intervention, there's an expectation of an increased pay or some allowances. The quality improvement structures and processes were quite weak in these facilities. There were no documentation and no follow-up of the action points. Lack of transition at service delivery points when the trained staff goes on leave. So every time a new staff was brought in, we actually were able to observe a decrease in uptake of services or a poor documentation. There was also lack of demand creation at facility and at community level. And lastly, there were also client-related challenges. Many of the clients were not ready to start oral PrEP immediately, and they requested for time to go and discuss with their partners. Others had fear of intimate partner violence. Some of them accepted to be referred but left before moving to the next service delivery point due to high queues or getting lost within the facility. Next. So moving on to just sharing the key lessons that we learned in this project. One of them was the routine engagement and co-implementation of FP and HIV services. Require engagement of the national, county, and sub-county levels, and ensuring that the health management teams are actually the ones who take lead in rolling out such interventions. And the roles need to also be clearly stipulated to include several capacity development initiatives. Then FP, HTS, and PrEP providers should be trained together, especially for this integration work. As I mentioned before, most of our providers operate like they are specialized in one specific thing and find it very difficult to transition and add on another service. So having all these 3 cadres or even additional cadres being trained to all understand what integration is all about and how they can support each other. And then given attrition and transfers, the providers training on PrEP FP integration should be institutionalized. Like having this as a standing topic in pre-service trainings and also supplemented by CME sessions. More than one provider in each of the service delivery points should be equipped to provide the integrated services. and also ongoing training on adolescent-friendly services is really key. Providers are conflicted when it comes to their values and the needs of the client, especially in HIV prevention. So we have to ensure that our trainings have a section or activities that address value clarification, that you can retain your value as a provider, but still be able to offer a service to somebody who needs it. Facility leadership was equally very important. In facilities where the site in charges took on this project, we saw those facilities working very smoothly and achieving as teams. Next. So also routine coaching and supervision is really important. And we saw this because we constantly engage the county and the sub-counties to do this coaching and supervision. As an organization, we were a facilitator, but then the counties took this up and the sub-counties and ensured that there was reduced provider biases in making decisions of the results of the RAST, and also ensuring that there was fidelity in following the procedures that had been laid down. Delivery of integrated services at facility level must be supported and reinforced throughout the health system. And this means ensuring that commodity shortages are addressed. PrEP-FP integration requires new M&E procedures so that we are measuring integration, but then also ensuring that there is ownership for sustainability. Best practices forums for sharing and learning really were a challenging factor for the providers. When they saw a facility doing better, the providers would actually go back to their facilities and plan, because we also ensured that we were rewarding facilities that were doing very well across the different indicators. So that was a motivator. Next. I think the last slide. Greater investment in awareness raising and demand creation for PrEP amongst AGYWs at the community and facility level were proved to be extremely important. Like when we trained the ambassadors and sent them out to go to the community, and also early morning hours, they would talk to their clients. We saw a better reception. You know, the providers would introduce HIV prevention and the clients would actually say, oh, somebody already mentioned that. So that helped with that smooth transition, and also just to help the providers, you know, reduce that burden and the time they take to talk through a particular product. However, what we realized is that there's little investment in the community structures and mechanisms like having ambassadors and peer educators being engaged by facilities directly, or even the counties themselves. So this really relied on implementing partners. Asking about IPV and providing appropriate support to clients who disclose also was very useful, because the facility then started coming up with how to create more awareness around IPV and also link clients to other services. To optimize the impact of integrated PrEP-FP services, they must be accompanied by effort to address the structural barriers. And also the quality improvement methodology is a promising approach. And we have shared this also with NASCOP that for us to see integration successful in Kenya, we have to make it a standing agenda for quality improvement, and facilities constantly looking for these bottlenecks and having you know, a multi-pronged approach to solving the problem of accessing services within an integrated model. And for further information, we have also just released a report of this particular project that can be found on the PrEP Watch website for further reading. So thank you very much. The last slide, just to acknowledge the partners that we have worked with. This was a USAID funded project, and we worked with a number of stakeholders, including FHI 360 in the country. Thank you very much for listening. Over to you.
Thank you, Patricia, for that insightful presentation. Let's give her some virtual claps. Would like to move to a plenary discussion. And this will be facilitated by Dr. Violet Oramisi. Dr. Violet Oramisi is a physician.
Good afternoon, Ruth. We are not able to hear you. I don't know.
All right, so thank you, Ruth. I don't know if you can hear me. I'm here with Ruth Kamau. Unfortunately, we had an interruption with our power, but Dr. Kiringo, can you hear us?
Yes, Doc, we can hear you now.
All right, thank you very much. So as Ruth has introduced me, I would just like to, first of all, appreciate my other co-facilitators in today's webinar, and to also thank everybody who was able to join. And just to continue just elaborating the importance of pre-exposure prophylaxis as part of prevention. So this first question, I would just like to ask it to Ruth Kamau on Kamau, why do you feel, I'm mainly from a strategic information background, and I just wanted Ruth to explain to us why, when we are providing pre-exposure prophylaxis services, why is it important for us to ensure that there's proper documentation of the services that we provide? Ruth?
So thank you, Dr. Ramisi. We are sharing a device because of our power outage. Ensuring that we have proper documentation practices for our PrEP services is very important, because one, we make sure there is data available for decision making, and we'd like to know the impact of pre-exposure prophylaxis, and we can only do this by looking back at the data that we have in our system. So we are able to know, are we averting HIV infection by use of PrEP? Is this product really working? We can only tell this from the data we collect. Thank you.
Yeah, so thanks Ruth for that. And I think as she has clearly said, the importance of data, most of us who have joined the call today are healthcare providers. And when we take assessments or conduct assessments once in a while, we actually find some gaps when it comes to documentation. Remember that if you don't document, then it is said that we have not, it is as good as not done. And right now, as we are tracking our progress, especially when it comes to pre-exposure prophylaxis, having started this, having introduced this and started the implementation way back when we introduced it in our guidelines in 2016, we have been able to see a lot of progress as a country, especially when it comes to reporting for our clients who are currently on PrEP, those who are continuing, those who are discontinuing, and even the disaggregation by age. And this is what has been able to inform us in terms of what other products then do we need to introduce, and how the uptake has been for the country. And this particular juncture, I would like to ask Patricia, one of our very key and supportive partner when it comes to monitoring and evaluation. I'd like to ask Patricia, when you have been supporting us as a program, what are some of the tools that you have use?
Hi, sorry, Dr. Ramisi. Your internet is breaking.
Especially when it comes to offering integrated services, because remember, provide this is in an integrated approach. We are using, sorry about that. Can you hear me now?
Yes, please come again.
Yes, so Patricia, thanks for that. Sorry, Patricia, just asking, what are some of the tools that we need in order to provide integrated services, especially for PrEP and sexual reproductive health services? Over.
All right, so thank you very much. I think the key tools, so one, I would start with the RAS, the risk assessment tool, which has very clear questions, and we can see how to integrate both from the HIV perspective and also from the FP perspective, so that the tool can be used for either. But also the second one, in terms of M&E, we need one tool that combines the key indicators for HIV prevention and indicators indicators for FP, because at the moment they are all siloed. You have the MOH tools for prevention and then the others for FP. So we need to find one tool that can combine those key indicators to help the providers in terms of documenting and also to ease the work. I would say those would be the key ones, but of course, there are also things like standard operating procedures and job aids, that combines both FP and PrEP, or SRH and PrEP.
Yeah, thank you, Patricia, for that. And you have put it very well that we need a combined tool for us to be able to provide these services. And maybe I would like to ask Ruth, as you're combining the tools, what are some of the indicators of interest that we need to ensure are captured when you combine these tools? Ruth?
Thank you, Dr. Ramisi. As we combine the tools, some of the indicators of interest will be, one, we have assessed for HIV risk. Maybe in all service delivery, we have assessed for HIV risk, assessed for eligibility for a contraceptive using the contraceptive RAST. And then we have numbers that are initiating PrEP and numbers that are initiating contraception. Then we have numbers that are coming for refills for both contraception and for PrEP. And then we also cannot forget the number that test HIV positive while on PrEP in all service delivery points.
Thank you, Kamau. Those are quite a number of indicators, but all very critical indicators and indicators that are of interest to us as the HIV and also the RH program when it comes to monitoring. Maybe the other thing that I would like to ask Ruth, that as we look at all the indicators that we've currently mentioned, just to help the healthcare providers and also the service providers who have joined in terms of reporting, how should they do the reports? How should they submit the reports so that we're able to monitor the services that are being provided? Ruth?
So thank you. Each facility should only provide one report at the end of the month. The frequency of the reporting should be on a monthly basis. So a facility that has different service delivery points should be able to collect this data in each service delivery point, then collect it at the end of the month and report as one facility report at the end of the month. Thank you.
Thank you. I think you have been able to understand that we have to do our reports on a monthly basis. That is basically the integrated reports that we submit nationally. And the other important component that Ruth has also been able to highlight, and I think it's also important for us to note, is that the reporting will also vary in terms of whether you are a paper-based site or you are also an EMR site. Because for the EMR sites, those are the electronic medical record sites, then we expect them to be able to upload their reports on a daily basis. And then this is now transmitted nationally through what we call the automated indicator reporting to the current reporting repositories that we have, one of them being the Kenya Health Information Systems, which currently hosts all the data for all the programs. As we are coming towards maybe some of the final questions that you want to ask, Patricia, would you maybe just be able to quickly highlight, once we have this data, we have collected the data has been integrated, we have reported the data, then how do our facilities utilize this data? How do the counties utilize this data? And also at national level, how do we utilize this data together as stakeholders? Because remember that at the facility, we work together with our stakeholders at the county level and at the national level. So how do we use this data? And maybe what are some of the other mechanisms that we need to put in place to ensure that there's data demand and use at all the levels? Patricia?
All right, thank you very much. So I would just use examples from this particular project. We used to have data meetings with the facilities on a monthly basis. So there would be someone who would go there an entire week to just help them put the data together. And so one, we would use the data to determine what are the missed opportunities within the facility. Where are we seeing a lot of drop-offs and why is that happening? So from that, we were able to find provider-related challenges and would be able to address them at facility level. If there were any shortages at any of the service delivery points, we were able to tell that just through the data, because the facility would explain any drop-offs, any client who did not get to the service delivery point, why did that happen? So it really helped to seal a number of gaps that were existing within the facilities, but then also highlighted where the facilities needed to put more efforts. Those kind of decisions can be made using this data at facility level. Now, if we go to the sub-county level and county level, again, this helps with programming in terms of how do we plan well for commodities? How do we plan when we are transferring staff from one facility to another, or we are reducing? What really determines that? What is the demand like within a facility, and how do we ensure there are sufficient staff to be able to serve based on the demand that is there? So it helps with just reorganizing the human resources for health, but also ensuring commodities are available and all the tools that are required are available. At national level, I look at this as one of the areas where, if we are constantly looking at our data, we will see where we have gaps and require to maybe prioritize our investments and put where we need to put in more efforts, and where we also need to invest in capacity building for the providers. Yeah, so I would say at this particular point, those would be key, and probably even in informing how do we diversify the delivery of these services, because we know in our country at the moment, a lot of the PrEP is provided within the CCC. But then people have constantly given us feedback. I do not want to go to the CCC to pick my PrEP. Can it be given in another service delivery point? So the big question is, what do we need to do in these other service delivery points so that we ensure that clients access these services where they want to access them from? And does that then lead to improved uptake of services or even continuation of those services? Yeah, so thank you very much.
Maybe in addition to what Patricia has mentioned, at national level, this data is useful because it helps us in quantifying for the commodities that are needed in the country. So we use the service data, and also.
Thank you very much, Ruth and Patricia. I really want to appreciate the comments and the inputs that you have been able to give on the importance of the data that we collect. And I think as the healthcare providers or the service providers, wherever we are, it is important for us to just appreciate the importance of documentation, because whatever we document, then it is used at different levels, and it impacts in terms of even the service delivery and even the quality of services that we provide. We have had challenges, especially when it comes to reporting of pre-exposure prophylaxis and also sexual reproductive health services in an integrated approach, but we have been able to see some improvement over the years. However, we are not yet there. And that is why today the panelists have been able to also just emphasize the importance of how we're using this data, and then what do we need to do with this data. So I really want to appreciate you all, and I want to request that as you continue providing services, please document properly, because you know that we utilize this level, the data that we have at different levels. So thank you, Patricia, and thank you, Ruth. Over to you, Ruth, for the other session.
So, yeah, thank you, Dr. Ramisi, for that facilitating that panel discussion. Would like to move to our Q&A, and I would like to start with Dr. Omu Anzala, who is raising their hand so that they can ask their question, and then we'll move to the Q&A to see if there are questions that we may not have responded to.
Yeah, thank you. Sorry, I joined in a bit late, but I'm glad that we are talking about HIV because COVID beat up on us, and it's like we have forgotten that HIV has actually not gone away. At CAVI, we are involved in a study at the moment looking at adolescent young girls and sex workers between the age of 15 up to the age of 24. And our interest really is to pick up their knowledge and understanding of multi-purpose preventive technologies. And so far, the data that has come in, I think we are not doing very well from the information we have picked up from the few girls that we have recruited so far. But I think part of it is what has been said here. Maybe we are working in silos. So those from NASCOP and Liverpool, maybe there is need to also just talk to us to see how we can actually be able to collaborate. And then my question is, since I came in late, I don't know whether information on the level of PrEP uptake was actually given. But then the question is that now we are moving on to long-acting PrEP. So could I hear maybe from NASCOP, what is the plan, for long-acting PrEP? Because it's on the
Daktari, you're breaking. We didn't get.
Could you hear me now?
Get your question. You're breaking a bit. Could you kindly,
okay,
yes,
so,
kindly repeat your question?
Yeah, so the question is that now that we are moving into long-acting PrEP, what is the plan from NASCOP of the long-acting PrEP, and what are some of the lessons learned from oral PrEP that we can take into long-acting PrEP to ensure that this time round, maybe we do things better? Over to you.
Yes, please. You'd like to answer? Just to make sure that we got you correctly, you are asking what is our plan on implementation of the long-acting PrEP.
Long-acting PrEP, it's coming. And then what are the lessons that you have learned?
So currently,
and what are the lessons we have learned from oral PrEP that we can actually use to ensure that long-acting PrEP, the uptake will be good, and all these other things that I've had the discussion going on. Over to you.
As the new products are emerging, the National Technical Working Group is considering them and actually including them in the guideline. Last year, when the WHO approved the ring, the pivoting ring, which is a long-acting product for women, it was actually adopted and included in our guidelines, and the guideline will be launched in the course of this year, maybe March, between March and April. So it is there. So we also know that the long-acting injectable is undergoing review by WHO, that the ring is also registered for in-country use. So once the products are available, it will be available for potential clients. And in the guideline, we have described who can use the ring. For long-acting, but once it is approved by WHO, it will be considered and included as part of the prevention options that are made available to our clients. On lessons that we have learned from oral, as we embark on rolling out the long-acting products, is that we are not going to establish any new systems. We are going to layer these products as additional options made available to our clients using the systems that are there. But one of the key lessons is that PrEP is for HIV negative people, and HIV negative people do not want to seek their services in the HIV care clinics. So we are moving towards offering services outside the CCC and testing approaches that increase access to our clients, like community delivery, e-pharmacy models, which are there. We still have, we are working to PrEP, making it more accessible in an environment that is free of stigma. So to also move to some other questions that are on the Q&A. And I see Ben Ochieng would like to answer one of the questions live. Ben, could you kindly unmute yourself and answer? The question on, after initiating PrEP to a client, I notice a silence on follow-up HIV testing to confirm successful prevention of infection. Kindly unmute and speak.
Yeah. So, okay. The guideline is once a client is initiated on PrEP and at the time of initiation. Hello, are you able to hear me?
Yes.
All right.
Yes,
all right,
go ahead.
So, all right, thank you for that. So at the time of PrEP initiation, HIV test is done, and once the client is confirmed to be HIV negative, then the client can now be initiated on PrEP following the assessment of other medical assessments. And thereafter, this client will be scheduled for a 1 month follow-up. At that point, then HIV test is also conducted, just to confirm if there was acute HIV infection or any other thing, or even assessing the side effects and the adherence of this client at that time. Thereafter, post 1 month initiation and HIV test, then this client will be HIV test will be done on a
Then we
in PrEP follow-up and or PrEP medication. So that is how it is done. So in case that is now the 3 months now you'll be doing, and then you'll be conducting this test, but again, you'll be monitoring on the PrEP adherence just to make sure that the client adheres well. And if there's some, you notice any defaulting or if the client is not adhering well, then you do the risk reduction counseling and other ways on how the client can adhere. So it is 1 month post initiation and then 3 monthly test, HIV test thereafter.
Thank you, Ben. Yes, as you have said it, and I had responded, I put that on the chat, responding to one of the questions. We do the test at enrollment or baseline, then at 1 month, then at the 3rd month, that is 90 days following initiation. Then thereafter, we do the test every 3 months. So moving on to some other questions, some of them we had answered on the charts, so you can read the charts, but I'd like to comment on the question from Stella Kanja, saying, good afternoon, thanks for the presentation. Kindly clarify, what does the law say about prescribing PrEP and all contraception to girls aged below the 18 years? So for PrEP, for contraception, I know the guideline, because there's we follow the guidelines that are approved by the Ministry of Health, and that is the government. So for contraception, we are guided, the guideline says 18 years and above. But for HIV, if you're able to identify that this person is at risk and they are emancipated minors and they are below 18 years and they are at risk of HIV, if they are eligible for PrEP and they are willing to start for PrEP, then they can be initiated on PrEP. Because for you to offer PrEP, this client must be able to consent for HIV testing. And the age for consenting for HIV testing is 15 years. So any person above the age of 15 years can be able to access PrEP services as long as they are over 35 kgs and they meet the criteria for eligibility. The other question is from Derek Mogambi. Is there any consideration to use private community pharmacies as point of distribution for PrEP? Yes, Derek, we have studies that are currently ongoing to see the effectiveness of pharmacy model for PrEP. However, at community levels, we have different approaches that have been used. For a client who is enrolled in a facility and they are picking their drugs in a facility, but refill is done within the community. That has been seen to work, especially among adolescent girls and young women, where maybe a community, a peer educator or a community health volunteer, or even a healthcare worker goes to the community with the products for some people in a safe space, and they dispense. The dispensing is done within the community. The other question from Sami Sibiu is, do we have any mitigation measures to put in case of a pandemic in future so that the numbers cannot go down? Patricia, would you want to respond to that? Maybe what you, sharing your experience, what you did in Mukuru? Or another, because I think you're implementing when the COVID pandemic first came.
Yeah, so thank you very much for that. I think there are very major key lessons that were learned that hopefully will also help us in terms of diversifying how we offer prevention services. And some of these strategies actually included that for as long as we had clients who understood their risk, they were already on PrEP, then we would make an arrangement of delivering their oral PrEP wherever they were. And they would only come back to the facility when they're due for their next HIV test. And also just linking those who are already on PrEP to other support systems where there were smaller groups that had been formed by those who are already taking oral PrEP. But I think in addition to that, in terms of creating demand is, moving electronic, and there were a lot of virtual campaigns that were done to continue reaching out to individuals who felt they were at substantial ongoing risk, but just did not know where to access certain services. So that kind of demand creation is one of the key lessons that we learned during the pandemic, that people did not have as much information as we had assumed they had. So ensuring that there's that flow and people are clear on where they can access services. Thank you.
So thank you, Patricia. And in addition to that, during the pandemic, we reviewed our guideline. PrEP clients used to collect their drugs on a monthly basis, but now after we have confirmed that they are actually HIV positive after maybe their the first month. If the client has good adherence, they can be given drugs for more than 1 month. But this is a decision the clinician needs to take, having evaluated the client. So another question from Joshua Wachilog is that we use TDF and FTC to treat hepatitis B infection. I have a lot of cases of hepatitis B in my site. Tell me the therapeutic role of PrEP in view of management of hepatitis B virus infection. I have clients with the hepatitis B virus infection. They come for PrEP molecule for treatment, but they are not addressing the issue. Kindly respond. One of the key requirements for a client when we are initiating them on PrEP is to take a sample for hepatitis B, because the molecule we are using for PrEP, it's either TDF and FTC, or TDF and 3TC is also used to treat hepatitis. So it is important for you to know the hepatitis B status of your client so that you manage them for both. As you're treating your hepatitis B, whatever you're giving them is also giving them protection against HIV. And so that you are able to make a decision for effective discontinuation in case the client wants to stop the medication. You ask your question like, have we managed hepatitis B? So it is important for us to take a hepatitis B test before initiating PrEP. But that should not delay decision to initiate PrEP. But we should educate our clients on the importance of having this test if it is not routinely done as baseline. You should make sure that maybe when they are coming back for their month 1 refill, they already have done the test and they are bringing you the results so that you are able to make those decisions. I don't know how much time we have. We continue answering the question.
Yes, we have about around 10 minutes, but we can
Okay.
see we've been able to, to answer majority of the questions. You can see how many we can be able to answer, then we wrap up. Thank you very much.
Okay, okay. So one more question from an anonymous attendee. It's always good to rename yourself. I know it's just I know it's just that I have been interacted with youth back in school while informing them on PrEP. Most of them were telling me how they wished to be informed of vaccines since taking drug is a burden. Yes, as we have heard from Dr. Omu, is that they are working on a vaccine, but for the time being, what we have is the oral PrEP, the dapivirine ring, and the hopefully cabotegravir that is coming on board soon, maybe in the course of this year. So the most important for them is to inform them of, help them appreciate their HIV risk and also take appropriate action to protect themselves. Dr. Vakil Shova is asking if we have any data on adverse events with PrEP. I know the data is available, but we don't have it here and now, but we can look for it. It is usually reported using the pharmacovigilance system. And when the client, the provider is documenting reasons for documentation, reasons for discontinuation, so they may, or if it is due to adverse effect, this can also be made available. So the other question, for another question from Edward Katai, would you give PEP to a patient on PrEP after a high-risk infection? So if a client is on PrEP and they have taken it for 7 days, then they don't need to be started on PrEP because the PrEP covers them and protects them against HIV. However, it is important for us to evaluate our clients very well when they come to us, because some of them may end up requiring PEP, not PEP, not PrEP. When they come to you and you hear that they had a high-risk exposure, maybe a day or two, within 72 hours, that client qualifies for PEP and not PrEP, so they should be given. So it is important to take a good history and evaluate and know actually if the client was recently exposed. If they were recently exposed, you give them PEP. If they were not recently exposed and there is plans for future exposure, you put them on PrEP and allow them to know that it takes up to 7 days for the PrEP to work. Michael Some says, thank you. I think this will help reduce infection, increase adherence. Hopefully, PrEP 2+1+1 for general population. How would a provider prescribe this med? Is it based on how many sexual sessions the client has? For example, 4 doses of PrEP, 2+1+1 for 4 sexual intercourses, meaning TCA will be. Patricia, would you like to just go through the 2+1+1? Are you able?
Yes, I am. Thanks for that.
Yes.
So the event-driven PrEP has been approved for use amongst men who have sex with men only. And so the requirement is that they take 2 pills of PrEP on the first day. And then after the sexual event, then they take 1 and then 1. So it's 2 at the start and then 1 and 1. And if there will be repeated exposure, they need to continue taking the 1 pill and continue taking it for like 48 hours after the last exposure. So it's 2 pills when you start, and then 1 pill and 1 pill after the exposure. So that's like 48 hours after exposure. So thanks, I hope that is clear. And it's only for men who have sex with men.
So, and then another important thing to note on this is that the event-driven PrEP is only indicated for people who are able to plan. They are able to plan for their sexual activities. It is not to be taken just somebody just decide I'll start taking event. So they know they will have a high risk exposure within 2 to 24 hours. And so they can start taking event-driven PrEP. So that's why it was initially approved for MSMs only, because studies done on that population showed that they are able to plan for their sexual activities. Sorry for the one who is saying is breaking. So there's somebody asking, why can't we give PrEP to people less than 35 kgs, but over 30 kgs, since we are transitioning TDF to the same group? Remember, products are approved and licensed for specific uses. Currently, the approval and the guidance we have is that for PrEP purposes, we can only give for over 35 kgs. So that's until that guidance is updated for pre-exposure prophylaxis, we limit ourselves to 35 kgs only. So there is Sami Simu asking if there are measures to put in place to prevent misuse of PrEP among enrolled clients. This is where the provider needs to make sure they provide adherence counseling to their clients, provide the appropriate information to the clients so that they know why they are taking the medication. And it is also important to allow them to know that the same medication we are using for prevention is the same one that is used even for treatment. So if they misuse it and they end up developing the issue, they developing resistance, the medication may not benefit them in future. So it is important to cancel them. The issue of hepatitis B, we have addressed it. We have said the same molecules are used for treatment. So it is important for you as a provider to make sure you offer hepatitis B surface antigen test as you initiate your client on PrEP, so that you know whether you are just giving your client a HIV prevention method or you are giving them and managing them also for another medical condition. How do you deal with the issue of use of PrEP by underage or minors? Do they require parental consent? We have said PrEP is only for people over 15 years, people who can consent for HIV testing. And if they are below 18 years, there must be evidence of emancipation. You have evaluated them and you have found that they are at risk of HIV. Maybe it's a child, they come to you, they are expectant. There must be evidence of emancipation. Thank you. Would you handle patient on PrEP who is exposed to infection risk, source that has been established resistant strain of HIV to PrEP regimen? Currently, what we are using for PrEP is only TDF-based regimens. Those are the only molecules that are approved for in-country use as PrEP. So if a client is exposed to a HIV resistant strain, as you're saying that it has been confirmed, then they need to be tested. And I think for that is to be tested. And if there's continuous exposure, they continue using other HIV prevention options. And if they're already exposed, they continue taking their PrEP, but test within a month. You test within 2 to 4 weeks to confirm if they were actually infected or not. We are not able to share all the slides to people who are posting their emails. However, we have shared these slides with the people at KNH. If they are able to share them from their end, they already have our slides and they can share with the team. So Macduff Ogwido is asking, great presentation. For discordant couple with male negative, how does one structure dosing if it is per 2+1 dosing? So for discordant couple, we said for 2+1+1, this person may be able to anticipate that they are going to have a high risk sexual exposure, and they start taking their PrEP medication within 24 hours or within 24 hours before that exposure. So if this person in a discordant relationship is able to anticipate when they'll have the high risk exposure, then they can be taking it. However, if their exposures are too frequent, then they don't need to take the event-driven PrEP. They need to switch to the daily oral PrEP so that they are continuously covered. I think those are all the questions that we are able to respond for now. We apologize, we are not able to answer all of them. I'll hand it over to the KNH team. Thank you for your time.
Thank you very much, Ruth Kamau, for that. You've actually answered a majority of the questions, and I think some of them have also been answered from the presentation. And so I want to also appreciate our participants for staying with us till now, and even for engaging and asking the questions. And we actually have a lot of comments even in the chat saying that this has been a very useful session, has been a very informative, and they have enjoyed the session. So we really want to appreciate. We'll give, maybe as we are coming to a close, we'll give maybe the final comments to the team. So we'll ask Patricia, maybe you can go ahead and give us your final comments. And we really appreciate that work that you've done with LVCT and the data that you have given us. Go ahead.
So on behalf of LVCT Health, I just want to appreciate you for inviting us to share this experience. And we are available to continue sharing it in whichever platform. And anyone who may want to reach out, the email is just my name, patricia.jekonaya@lvcthealth.org, and I can be able to provide additional information. Thank you very much to NASCOP, to UoN and KNH. Over to you.
Thank you very much. Dr. Ramisi, you're with us?
Sorry, Dr. Ramisi has stepped into another meeting.
Oh, okay, you can go ahead and give us your final comments. And thank you so much for this very wonderful presentation.
Okay, we appreciate the opportunity to make this presentation, and we look forward to continued collaboration. Just a little emphasis to our healthcare providers that seize every opportunity you can to offer to assess a client for HIV risk and offer them appropriate HIV prevention information and method where applicable. And with that way, we'll be able to reduce our HIV transmission rate one client at a time. Thank you. Over to you, Dr. We are done.
Oh, sorry, Dr. Limited. Thank you so much for that. I'd actually also want to appreciate part of our panelists who are there in the background and who have been with us in the session, Professor Omo Anzala. We had Dr. Owende earlier, Dr. Kihara. You can see we have Prof. Wanyoro on board, Prof. Omondi Ogutu. We really do appreciate you for joining us. And also to our partners who have enabled us to have this session. We have a representation from the Gilead team. We really appreciate the support. And to our team here at the KNH Medical Research, thank you for enabling this session, for making the presentation go easy, and for the posters, we really do appreciate. To our participants, thank you. We'll have the presentations on in our website, at the KNH website. they will be there, and also the recording, it will be on in the website. It will be uploaded in the website. Now that we have the go ahead from the team presenting, we really appreciate that. For the CPD points, for the nurses, you have your posters on that you need to put in within 48 hours. For the doctors, you'll have them emailed. And for the pharmacists, we'll have them up on the PPB portal in due time. We are in communication with the team, and we also have the registers ready just for to have your points in good time. So we have noted that. Thank you so much, everyone. We now bring this session to the end. Have a lovely afternoon. Thank you.
Thank you too.